to say for any trauma patient you're going to do absolutely this, this, and this. But I think that time is one thing. And the thing is, too, is that a lot of the paramedics, they say, oh, yeah, we've been doing it for 15 minutes, and, you know, things go fast when you're in an ambulance. And it's difficult, I think, sometimes to even tell whether or not someone has a pulse when you're bouncing along in an ambulance on the way in. So it's variable. So I know that's not a good answer, but I don't think there is a good answer.
Which in and of itself is a good answer.
But I think you need to focus on, instead of the ACLS that we're used to, you have to focus on that the trauma patient's a little bit different in that it's almost always a volume problem. Mm-hmm. There's a reason that they're arresting, almost always. Now you have to rule out, obviously, the pneumothorax and those sorts of things, but it's almost always a volume problem. And even the things that are not, like tamponade and pneumothorax, can be fixed a lot of times with some volume as well.
Mm-hmm. Now, is there any benefit over the tube thoracostomy versus just a finger thoracostomy? And so we're out in the community, some of us will go out and be practiced. We might just get that nearest receiving. You know, if you don't have the resources, is there really any difference between just putting a finger in, spreading it out? I mean, you're going to relieve any tension, any blood. I mean, as far as that minimum resuscitation toward that blunt trauma victim, let's say.
Well, you know, I've actually had somebody do that, I think, because if we get into the chest and we just want a diagnosis, whether or not there's air or blood inside the hemothorax, you can just open it up and relieve whatever's in there, and if there's a tension pneumo, it'll be relieved. But if you're going to be recovering that patient, if the patient is actually going to gain vitals back or those sort of things, you obviously have to put in the definitive tube. But I think for a diagnostic maneuver, I've done that as well, where you just put a cut in the chest and see whether or not there's anything in there, whether or not you get air, whether or not you get return of vitals, those sorts of things. I think that's a reasonable thing to do. But if you get them back, you obviously have to do the definitive thing.
So then that brings us to the ED thoracotomy. The ACSCOT, everything was about emergency thoracotomy. They made this statement: emergency thoracotomy does not appear to have a role in blunt trauma-associated CPA, and that kind of started this avalanche of literature in the trauma literature about no, this actually has some merit, it has some benefit. Denver Health, the Western Trauma Association have shown injury alone not to be a predictor of resuscitated futility. Where are we currently at in what's accepted among the trauma surgeons at the role of ED thoracotomy and who it applies to?
Well, in penetrating trauma, I think there's a clear role in the patient who has a thoracic injury or even a torso injury and is arresting. Because sometimes it's difficult to tell whether or not that abdominal wound has traversed into the thorax or has traversed through the mediastinum, and there's something definitive. So I think that in penetrating injury, it's clear, there's a clear role for it. But again, with the caveat that if they're shot in the head, you're not going to do much with the thoracotomy, and there's no other injuries anywhere. In blunt trauma, there has been some things, actually most recently coming out, about its role in blunt trauma. The problem is I think we run into a lot of injuries that that may not be fixable. Most of the time, in blunt trauma, it's very difficult to tell what they're dying from, as opposed to a penetrating. You can kind of guess if there's a gunshot wound in the torso, it's something between the neck and the pelvis. Whereas in blunt, it's very difficult to tell what they're dying from sometimes. And so I think that's part of the reason that, and most of the time it's not something that you can fix through a thoracotomy. If it's a thoracic aortic injury, you're just going to run into a big mess because there's no way that you can fix that at the bedside or alleviate that at the bedside, or even, usually they're dead in about 5 heartbeats. So those types of patients, there's not much of a role in. The one thing that does happen in trauma patients but is often fatal is pericardial tamponade. And that's one thing that, fortunately, we have a way of determining whether they have that or not with ultrasound. So I think that is one thing that definitely can help guide us into whether or not a thoracotomy would be useful in those patients or not. And that would be the only thing that I can think of that would actually be fixable in somebody's chest. There are some people who avulse their lung and things like that that could also, but you're going to be putting chest tubes in these patients initially. So I think without putting chest tubes in and without having an ultrasound that shows that you have something there, there's not much that you're going to be able to fix with a thoracotomy or at least temporize like you can in a thoracotomy for penetrating trauma. So I think that we've had, I don't think we've had any for blunt trauma in a long time. But we've also not had any tamponades from blunt trauma. It's pretty difficult to do that. We don't get a lot of actually bad blunt trauma at this institution because we're kind of far away from a lot of the highways. We're kind of nestled in the suburbs. So for us to get a lot of bad blunt trauma is pretty rare. We're getting a lot more now because of the Olympia Fields closing, and we get a lot more transfers from Indiana than we used to. But those patients are usually determined at the accepting institution before they get to us. So it's usually not something that we're doing a lot of. So for us, we don't see a whole lot of that. But you're right. There is some people who are moving towards doing that more again. But again, if they're down for more than 10, 15 minutes, it's usually pretty futile after that to have a survivor.
I think from the Western Trauma Association, they came out with guidelines in 2011 and said, thoracotomy might be indicated for blunt trauma with greater than 10 minutes without ROSC, penetrating greater than 15 minutes. The initial presenting rhythm is asystole without evidence of pericardial effusion. Those, they said, there's no indication whatsoever to a thoracotomy. Would those be pretty much?
Yeah, and I just don't think that we do very many for blunt trauma. We just really don't.
Right.
And if that's changing in the trauma world, then that's new, because we've also reserved that kind of a procedure for people who are penetrating, because we've had such poor outcomes with that. I mean, you have to think of the other things that are negative about thoracotomies. It's a huge resource waste. It is a huge opportunity for exposure, which is in a blunt trauma going to be even higher because of the massive thoracic wall trauma that a lot of these patients have. And I've seen multiple people injured, residents, attendings, during that procedure. And so that's another problem, even though I don't want to withhold life-sustaining or aggressive therapy in people who are in trauma, but we have to have that on the other end of it. And I think that's part of the reason that we had moved away initially from doing a lot of blunt thoracotomy resuscitation.
Can we take a quick aside to pediatric traumatic arrest? Is anything in your mind globally different about the pediatric traumatic arrest versus the adult traumatic arrest?
Not in my mind, but I'm not a pediatric surgeon. So, I mean, in children, obviously they have a different type of response to the reserve that they have. So they become very tachycardic and stay tachycardic until they almost die. And so they respond to hypovolemia very differently. So it's just important to note that. Also, you can lose more blood in, say, for instance, in infants in the head and those sorts of things. So you have to know that your hypovolemia may be from some different things. But babies and things like that, to be quite honest with you, I don't have a lot of experience with in terms of, because I'm not a pediatric surgeon. I leave that to them. But for the kids that are my size or larger, we treat them much like adults. If they're in L&OMI unit or larger, and they're physiologically like an adult. So.
And the last topic that I think is probably the most controversial that I really would love to hear your thoughts on would be organ donation and the maintaining of perfusion in patients artificially for the sake of being able to harvest their organs later. Where are we at with the ED's role of salvaging the unsalvageable for the sake of maintaining their organ perfusion?
Well, I think that if you have a patient who has an obvious brain injury and they're back back after the CPR that you've done and they've maintained their vitals, and then they kind of chill out and keep their vitals maintained for a longer period of time, then I think that there's not a lot of decisions you have to make. You have their perfusion restored, and you just have to resuscitate them. Determination of brain death in those patients usually is a 24-hour process. And so in order to get to that point, they have to be maintained for at least that amount of time. So if the patient is maintaining their own perfusion and maybe they have a couple drops in blood pressure that respond to fluid boluses and things like that, and I think it's reasonable for you to continue to maintain that. Clearly an obvious conversation has to be had with the family in terms of what the prognosis is, if you think they've progressed to brain death from a head injury or something like that, because that's usually the type of patient you're going to be looking at. However, if they appear to be brain dead, yet they have a splenic injury and they have to go to the operating room to get their spleen out, again, you can't just determine that they are brain dead at that point in time, because it's a process that you have to go through. We don't just give out brain death diagnosis willy-nilly. So it's something that takes time to do that determination. So if you have somebody who's maintaining their perfusion, they're in the ER, you think they're brain dead, continue with the course until we can prove that they're dead otherwise, because they're not dead till they're dead, okay, until they've determined that. And here in this institution, that is at least 6 hours, and if they just arrested, a 24-hour process, okay? That's what our policy says here. So you need to be able to maintain them for that amount of time. Now, if you have somebody who's arresting 3 or 4 times in a row, I think that as a physician you can determine that futile, especially if they continue to arrest time after time after time after time. And we know that even if you've gotten them to scan or whatever, and you know that they have a devastating brain injury, then we have determined that that is a futile endeavor. Because sometimes these patients become extremely hemodynamically unstable. And if they are like that, a lot of times their organs are not usable. So to maintain them, I think that that's how you have to look at it, is that I can't really determine that this patient is brain dead until they're actually dead, you know. And again, it's a process. They have to go through an apnea test, they have to go through 2 exams, and if they can't tolerate an apnea test, they have to go through a confirmatory study where they have to go down to nuclear medicine for a couple of hours and sit there and do a brain perfusion or get an angiogram or transcranial Doppler here, but that's not very good test. So.
Ultimately, are we serving the community at large by, I don't want to say wasting, but wasting these resources you're talking about, nuclear med scans, all these other tests, by keeping them perfused?
Well, what's your other option though? If they have a perfusing blood pressure and a heart rate, you don't have a choice until you determine that they're dead. See what I'm saying? If they continue to code every 5 minutes, then eventually, 1, it's going to not work anymore.
Mm-hmm.
And 2, if they did have a survivable brain injury that would have come to light, it's becoming less and less and less survivable every time you do CPR on that patient. So determining futility in that person, depending on the situation, is something that would be reasonable. So I think you have to look at it not so much as the organ donation part, but the fact that you can't determine death until you can determine death.
I gotcha.
So, which is a process to go through.
Uh-huh.
And yeah, you could say, well, we think that this patient is dead, but we can't prove that until we had one patient just this last week who was an assault to the head with a baseball bat, and he had enormous amount of swelling, and all of a sudden he just stopped breathing. Just stopped breathing. He was fine for 24, 48 hours, and he just stopped breathing, and he died like that. But we had to wait a full 24 hours in order to do the brain death determination because he had arrested in the process, had to be intubated, all that stuff. And so we had to wait that 24 hours. We had to give him CPR. We had to do everything until we could determine that. So.
Well, thank you very much for donating your time. If anybody has any questions, please email them to me. I will email them on to Dr. Omi, and we'll post them up on the web. Again, please send me your feedback so that we can make these interactions better and better for the future. Thank you very much for your time, and it was very helpful.
Thank you. Thank you so much.